Welcome to Pediatric Case Review. Today's lecture covers Cornelia de Lange Syndrome, a rare genetic disorder with distinctive clinical features. We will explore clinical presentation, examination findings, pathophysiology, diagnostic approaches, treatment strategies, and associated complications. This comprehensive review aims to enhance your clinical recognition and management skills for this complex condition. A 6-month-old infant presents with developmental delay. On examination, you note synaphrese, which is joined eyebrows, long eyelashes, anteverted nares, and a thin upper lip. Growth parameters show both weight and length below the 3rd percentile. What is the most likely diagnosis? Option A, Rubinstein-Taybi syndrome. Option B, Cornelia de Lange syndrome. Option C, Smith-Lemli-Opitz syndrome. Option D, Noonan syndrome. The correct answer is B, Cornelia de Lange syndrome. The combination of synaphrese, which means joined eyebrows in the midline, along with long curly eyelashes, anteverted nares, and thin upper lip are highly characteristic. Synaphrese is considered nearly pathognomonic for this condition. Growth restriction is typically present from early infancy, making early recognition crucial for appropriate management. A newborn with classic Cornelia de Lange syndrome facial features undergoes limb examination. You note small hands with proximally placed thumbs. The right hand shows absence of the 2nd and 3rd fingers. What is the spectrum of limb abnormalities in Cornelia de Lange syndrome? Option A, only mild oligodactyly. Option B, ranging from small hands to severe reduction defects. Option C, primarily lower limb involvement. Option D, no limb involvement occurs. The correct answer is B. Limb abnormalities in Cornelia de Lange syndrome show remarkable variability. They range from mild findings like small hands and clinodactyly to severe reduction defects, including oligodactyly, phocomelia, or complete limb absence. Upper limbs are more commonly and severely affected than lower limbs. The severity of limb involvement often correlates with overall syndrome severity and genetic mutation type. A 2-year-old child with confirmed Cornelia de Lange syndrome had a birth weight of 2.1 kilograms at term, which was below the 3rd percentile. Currently, weight and height remain below the 1st percentile, while head circumference is at the 3rd percentile. Which growth pattern is typical for Cornelia de Lange syndrome? Option A, normal prenatal growth with postnatal failure. Option B, prenatal and postnatal growth restriction. Option C, macrocephaly with normal body growth. Option D, catch-up growth by age 2 years. The correct answer is B. Cornelia de Lange syndrome typically shows both prenatal and postnatal growth restriction. Intrauterine growth restriction is common, with birth weights usually between 2 and 2.5 kilograms at term. Growth failure continues postnatally without catch-up growth. Microcephaly develops in approximately 85% of cases. Interestingly, growth hormone deficiency is not a primary cause of the growth restriction. An 18-month-old child with Cornelia de Lange syndrome is not yet walking independently. Language development shows no words and limited babbling. However, social interaction appears relatively preserved with good eye contact and responsive smiling. What is the typical developmental profile in Cornelia de Lange syndrome? Option A, isolated motor delay only. Option B, global developmental delay with variable severity. Option C, normal development in most cases. Option D, regression of previously acquired skills. The correct answer is B. Global developmental delay with variable severity is characteristic. Intellectual disability occurs in 99% of cases, ranging from mild to profound. Language development is typically the most severely affected domain, while motor skills may be relatively better preserved. Social skills are often a relative strength. Unlike some genetic conditions, developmental regression is not typical in Cornelia de Lange syndrome. A newborn with Cornelia de Lange syndrome features has a grade 3 out of 6 systolic murmur at the left sternal border. Respiratory examination shows mild tachypnea without significant distress. The infant tires easily during feeding. What is the prevalence of cardiac defects in Cornelia de Lange syndrome? Option A, less than 10%. Option B, approximately 30%. Option C, about 50%. Option D, nearly 100%. The correct answer is B, approximately 30%. Cardiac defects occur in about 1/3 of patients with Cornelia de Lange syndrome. The most common is ventricular septal defect, followed by atrial septal defect and pulmonary stenosis. More complex defects like tetralogy of Fallot can occur, but are less common. Echocardiography is recommended for all patients at diagnosis for detection and appropriate management planning. A 6-month-old with Cornelia de Lange syndrome shows poor weight gain. The infant has frequent vomiting and arches during feeds. Examination reveals significant irritability after eating. Growth charts show dropping percentiles despite reportedly adequate intake. What is the most common gastrointestinal problem in Cornelia de Lange syndrome? Option A, malabsorption syndrome. Option B, gastroesophageal reflux disease. Option C, pyloric stenosis. Option D, chronic diarrhea. The correct answer is B. Gastroesophageal reflux disease is the most common gastrointestinal problem, affecting 50 to 80% of patients. Contributing factors include hiatal hernia and delayed gastric emptying. Other common issues include constipation and feeding difficulties. Serious complications like intestinal malrotation and volvulus are rare but important to recognize. Management includes medical therapy with proton pump inhibitors, and some patients require surgical intervention. A 5-year-old with Cornelia de Lange syndrome exhibits self-injurious behaviors, including hand biting and frequent screaming episodes. Socially, the child avoids crowded areas and strongly prefers routine. Sleep patterns show frequent nighttime awakening. Which behavioral feature is most characteristic of Cornelia de Lange syndrome? Option A, hyperactivity and impulsivity. Option B, self-injurious behavior and anxiety. Option C, aggressive behavior toward others. Option D, absence of behavioral problems. The correct answer is B. Self-injurious behavior occurs in 40 to 60% of patients, commonly including hand or arm biting and head banging. Anxiety and sensory sensitivities are frequent. Autism spectrum features appear in 50 to 70% of cases. Sleep disturbances are common. These behaviors often respond to structured behavioral interventions, environmental modifications, and sometimes pharmacological management when severe. The parents of a child with Cornelia de Lange syndrome ask about the genetic cause. There is no family history of similar cases. They want to understand which genes are involved. Which gene accounts for most cases of Cornelia de Lange syndrome? Option A, NIPBL gene on chromosome 5. Option B, SMC1A gene on the X chromosome. Option C, MECP2 gene on the X chromosome. Option D, FMR1 gene on the X chromosome. The correct answer is A. The NIPBL gene on chromosome 5 accounts for 60 to 70% of cases. Other genes include SMC1A, SMC3, RAD21, and HDAC8. These genes regulate the cohesin complex, which is essential for chromosome segregation and gene regulation. Most cases result from de novo mutations. Recurrence risk for typical cases is low, less than 1.5%. Genetic testing confirms diagnosis in 70 to 80% of cases. An infant is suspected of having Cornelia de Lange syndrome based on clinical features including synaphrese, limb anomalies, and growth restriction. What is the best initial diagnostic test? Option A, brain MRI. Option B, chromosomal microarray. Option C, targeted genetic testing for Cornelia de Lange syndrome genes. Option D, metabolic screening. The correct answer is C. Targeted genetic testing for Cornelia de Lange syndrome genes is the best initial diagnostic test. Start with NIPBL gene sequencing and deletion testing. If negative, proceed with panel testing for other associated genes. Clinical diagnosis is possible with classic features, but genetic confirmation is valuable. Additional recommended tests include echocardiogram, upper gastrointestinal series, baseline audiology, and ophthalmology evaluation. An 8-month-old with Cornelia de Lange syndrome has severe feeding difficulties. Each feed takes 45 minutes with frequent gagging. Weight remains consistently below the first percentile. Gastroesophageal reflux disease is managed with medication. What intervention may be needed? Option A, increase oral feeding frequency only. Option B, gastrostomy tube placement. Option C, parenteral nutrition. Option D, no intervention needed. The correct answer is B. Gastrostomy tube placement is often necessary for patients with severe feeding difficulties, prolonged feeding times, aspiration risk, or poor growth despite interventions. Benefits include improved nutrition and decreased aspiration risk. Management requires a multidisciplinary approach, including feeding therapy, gastroenterology, and nutrition services. Many patients with Cornelia de Lange syndrome require tube feeding support. Oral feeding should still be encouraged alongside tube feeds when safe. A newly diagnosed 1-year-old with Cornelia de Lange syndrome requires care planning. The family asks about required specialists. Current issues include developmental delay, gastroesophageal reflux disease, and hearing concerns. Which specialists are typically needed for comprehensive management? Option A, only pediatrician follow-up. Option B, pediatrician and 1 specialist. Option C, multiple specialists across disciplines. Option D, no ongoing specialty care needed. The correct answer is C. Comprehensive management requires multiple specialists across disciplines. Essential specialists include genetics, developmental pediatrics, and gastroenterology. Important consultants include cardiology, ENT, ophthalmology, and orthopedics. Therapy services include physical therapy, occupational therapy, and speech therapy. Behavioral support from psychology or psychiatry may be needed. Regular monitoring and coordinated care through a medical home model are crucial for optimal outcomes. A 3-year-old with Cornelia de Lange syndrome has speech development concerns. History reveals recurrent ear infections. Examination shows bilateral middle ear effusions. Audiology testing demonstrates mild conductive hearing loss. What is the prevalence of hearing loss in Cornelia de Lange syndrome? Option A, less than 10%. Option B, approximately 25%. Option C, about 60%. Option D, nearly 100%. The correct answer is C. Approximately 60% of patients have some degree of hearing loss. Types include conductive, which is most common, sensorineural, or mixed. Causes include recurrent otitis media and structural ear anomalies. Management may include tympanostomy tubes, hearing aids, and intensive speech therapy. Regular audiology screening is essential. Hearing loss significantly impacts language development, which is already a challenge in Cornelia de Lange syndrome. A 2-year-old with Cornelia de Lange syndrome attends ophthalmology screening. Examination reveals bilateral ptosis and myopia. An additional finding is nasolacrimal duct obstruction. What is the most common eye finding in Cornelia de Lange syndrome? Option A, cataracts. Option B, myopia. Option C, glaucoma. Option D, retinal detachment. The correct answer is B. Myopia is the most common ophthalmologic finding. Other frequent findings include ptosis, occurring in approximately 70% of patients, and blepharitis. Nasolacrimal duct obstruction is a structural abnormality seen in many cases. Less common findings include nystagmus and strabismus. Optic nerve hypoplasia is rare but serious. Annual ophthalmology examinations are recommended for screening and early intervention of treatable conditions. A 4-year-old with Cornelia de Lange syndrome experiences a first seizure. The seizure was generalized tonic-clonic lasting 3 minutes. Brain MRI shows mild cerebral atrophy. EEG demonstrates generalized spike wave discharges. What is the prevalence of epilepsy in Cornelia de Lange syndrome? Option A, less than 5%. Option B, approximately 25%. Option C, about 50%. Option D, nearly 75%. The correct answer is B. Epilepsy occurs in approximately 25% of patients with Cornelia de Lange syndrome. Seizure types include generalized seizures, focal seizures, and sometimes infantile spasms. Brain imaging may show cerebral atrophy or delayed myelination. Management follows standard anti-epileptic drug protocols. Interestingly, an increased pain threshold has been documented in many patients. Regular neurological monitoring and prompt seizure evaluation are important. A 7-year-old with Cornelia de Lange syndrome undergoes dental evaluation. Findings include small, widely spaced teeth. Oral health assessment reveals multiple cavities and poor hygiene. Additional findings include high-arched palate and micrognathia. What dental problems are common in Cornelia de Lange syndrome? Option A, dental health is typically normal. Option B, delayed eruption and hypoplasia. Option C, supernumerary teeth only. Option D, early tooth loss only. The correct answer is B. Delayed tooth eruption and dental hypoplasia are common. Other findings include small teeth, wide spacing, and sometimes oligodontia, which means missing teeth. Structural abnormalities include high-arched palate and micrognathia. Oral hygiene is challenging due to behavioral issues and motor difficulties, leading to increased dental caries risk. Regular dental care with preventive fluoride treatment is essential for maintaining oral health. A 10-year-old with Cornelia de Lange syndrome has progressive scoliosis. X-ray shows a 35-degree thoracic curve. Additionally, bilateral radioulnar synostosis is noted. Physical examination demonstrates limited forearm rotation. What orthopedic problems may occur in Cornelia de Lange syndrome? Option A, scoliosis only. Option B, multiple skeletal abnormalities. Option C, no orthopedic involvement. Option D, only lower limb problems. The correct answer is B. Multiple skeletal abnormalities can occur. Spinal problems include scoliosis in approximately 25% of patients and cervical spine anomalies. Upper limb issues include radioulnar synostosis and elbow contractures. Hip dysplasia and dislocation may occur. Foot abnormalities include clubfoot and PS planus. Regular orthopedic monitoring is important, with surgical intervention when indicated for functional improvement. A 3-year-old with Cornelia de Lange syndrome has frequent respiratory infections. The history reveals 8 episodes of pneumonia in the past year. Immunoglobulin levels are requested. Are immune deficiencies common in Cornelia de Lange syndrome? Option A, yes, severe immunodeficiency is typical. Option B, mild immune dysfunction may occur. Option C, no immune problems occur. Option D, only autoimmune conditions occur. The correct answer is B. Cornelia de Lange syndrome is not a primary immunodeficiency syndrome, but mild immune dysfunction may occur in some patients. Frequent respiratory infections are usually related to aspiration, gastroesophageal reflux, and anatomical issues rather than true immune deficiency. Some reports describe mildly decreased immunoglobulin levels. Consider immunologic workup if infections are very frequent or severe, but most patients have relatively normal immune function. A 5-year-old with Cornelia de Lange syndrome is scheduled for gastrostomy tube placement. History includes gastroesophageal reflux disease and micronathia. Cervical spine has not been evaluated. What are important anesthesia considerations? Option A, no special considerations needed. Option B, difficult airway and cervical spine precautions. Option C, only standard preoperative assessment. Option D, surgery should be avoided. The correct answer is B. Important anesthesia considerations include difficult airway management due to micronathia, high palate, and short neck. Cervical spine imaging is essential before surgery to identify instability. Gastroesophageal reflux increases aspiration risk. Cardiac status must be fully evaluated. An experienced anesthesia team familiar with craniofacial abnormalities and syndromic patients is strongly recommended for optimal safety and outcomes. Parents of a newborn with Cornelia de Lange syndrome ask about prognosis. They are concerned about long-term survival and quality of life. The infant has classic features with moderate severity. What factors influence life expectancy in Cornelia de Lange syndrome? Option A, all patients have normal life expectancy. Option B, severity of cardiac and gastrointestinal complications. Option C, life expectancy is always severely reduced. Option D, only limb abnormalities affect survival. The correct answer is B. Life expectancy is influenced by severity of cardiac and gastrointestinal complications. Many patients with Cornelia de Lange syndrome survive to adulthood. Mortality is higher in infancy and early childhood, primarily related to severe cardiac defects and aspiration complications. Patients with mild cases may have near normal life expectancy. Quality of life varies considerably, but can be optimized through comprehensive multidisciplinary care and early intervention. Thank you for joining Pediatric Case Review for this comprehensive lecture on Cornelia de Lange syndrome. Key takeaways include the importance of early recognition through characteristic facial features, confirmation with genetic testing, and comprehensive multidisciplinary management. Please follow our channel for more informative medical presentations. If you have any questions or interesting cases to discuss, please leave a comment below. We appreciate your engagement and look forward to continuing your medical education journey with us.